Okay, this is the first chapter, that is the chapter number 21. Okay. So let us start. Bismillahirrahmanirrahim. This is about the genomic imprinting, one type of the mutation. When you will see the chapter of the SOP, first of all, I will show you. Okay, this is the genetics chapter. The important points we have to extract from this chapter, like what is the disease, what is the mutation in that disease. Okay, like if I talk about like your Duchenne's muscular dystrophy, is this mutation, deletion? Okay, and which type of the test that is more diagnostic for making these mutational like diagnosis. I just wanted to tell you like what are the diseases where fish is the diagnostic investigation of choice. We must know what are the diseases where the karyotyping is the investigation of the choice. So they have told us here about the chromosomal testing, where fishes like investigation of the choice, which are the diseases where this array genomic imprinting, that sorry, genomic hybridization, that is the investigation of the choice. Okay, now you must know what are the types of the mutation. What is aneuploidy? Okay, what are the diseases where sex chromosome aneuploidy is present? What are the diseases where autosomal aneuploidy are present? Okay, right. And autosomal dominant, autosomal recessive, we all know that they usually do not ask much about autosomal dominant, recessive, and X-linked recessive. We all know the diseases, the types which are like under these headings. But important in this exam is like you have to know which investigation is most important to make the diagnosis of this disease. And very, very important, very interesting, very favorite question for them is what is genomic imprinting. Okay, this one. There are three imprinting disorders, genomic imprinting disorders. We will read that clinical case. Just before that, I just wanted to tell you this imprinting disorders, there are just three disorders we need to know. One is your Angelman, one is Prader-Willi syndrome, and the third one is Beckwith-Wiedemann syndrome. These three syndromes, they come under the heading of the imprinting disorders. Okay, others, see here they have told you other imprinting disorder. This is Albright osteodystrophy, this is transient neonatal diabetes mellitus. So these are five. The first three one which I have mentioned, these are the most important ones. We must know what is the recurrence of these disorder in the next pregnancies, in the next children, and what are the basic causes of these imprinting disorders. Okay, keeping this imprinting disorder in your mind, we will read our first case, that is from the TOS case number 21. Okay, so start it. As she's a 16-year-old girl, a 16-year girl with Prader-Willi syndrome. Okay, she is a girl. She's a known case of the Prader-Willi syndrome, secondary to uniparental disomy. She attends the clinic with her parents. Okay, during discussion, her parent asked you if she were to be pregnant, whether the baby is likely to born with Prader-Willi syndrome. Okay, first of all, you tell me what is Prader-Willi syndrome. This is an imprinting disorder. Any idea about imprinting disorders? You have read about this one. What is imprinting disorder? What is imprinting disorder? Any idea? Dr. Hira, Dr. Kuratulan, any idea about the imprinting disorders? Okay, let us start it. Like, how many chromosomal pairs are present in my body? See here, every cell. Okay, every cell we have 46 chromosomes. In other ways, we can say we have 22 pair of autosomes and one pair of the sex chromosome. Okay, so if I see on my karyotyping, I have this much like 22 pair of the autosome. This one starting from the number 1 chromosome pair and number 22 chromosome pair, and the sex chromosome, that is XX. Okay, so this is a chromosomal pair. Should not make, okay. This is a chromosomal pair. One part of this chromosome, it has come from my mother, and one part of this chromosome, it has come from my father. Okay, we know many mutations, like there can be deletion. Some part of the chromosome, if it is absent, that is known as deletion. It is deleted. Okay, duplication means some part of the chromosome or some gene that is duplicated instead of one that is duplicated. Okay, we know about the trisomies, like instead of the two chromosomes, there are three chromosomes which are present. That is trisomy. Okay, then what are aneuploidy? Aneuploidy means extra or incomplete number, like odd number of the chromosomes, maybe three chromosomes, maybe one chromosome. Aneuploidy means the number of the chromosome that is not in pairs, that are not in even number. Like if we talk about the 45x0, that is aneuploidy of your sex chromosome. Okay, if we talk about our trisomy 21, that is also aneuploidy. There is odd number of the chromosome that is present. Normally there should be a pair of the chromosome, one from the mother, one from the father. There may be deletion, there may be duplication of the chromosome, there may be trisomy, like we must say there may be aneuploidy, where there is an odd number of the chromosome is present. Maybe one number, three number, nine number, seven number, something like this. Okay, these are aneuploidy. I want to talk about the imprinting. Imprinting means what? I should receive one chromosome from my father, one chromosome from my mother. Okay. Imprinting means I will not talk about the predator, this one. I have this chromosome from my mother, but that is deleted. That is imprinted. Okay. This is known as imprinting. The part of the chromosome, it has become the gene on this chromosome. They have become silent. They have become dysfunctional. This is the genomic imprinting. This chromosome I have taken from my mother, but it is deleted. Okay, you got this point? This is one type of the imprinting disorder. In other type, where we know like this is the P, we always memorize Prader-Willi, that is from the paternal. See here, what is happening here? Instead of receiving this chromosome from my mother, okay, I received this chromosome number 15 pair. This was from my father and another one also from my father. This is known as uniparental disomy. Okay, one pair of the chromosomes, usually your chromosome number 15, that is not coming from one from the mother, one from the father. This is a uniparental disomy. I got my two chromosome at 15 number from either from my father or from my mother. Okay, this is uniparental disomy, which is usually considered a part of the imprinting disorder. One is the deletion, which is usually present in many cases. But see here, the deletion is only of one parent chromosome. Like if I talk about here, if I say the Prader-Willi syndrome, what is my interpretation for the Prader-Willi syndrome? I usually consider the chromosome which I has taken from my father, that is abnormal. Okay, I see, I make it like this. This is my chromosome number 15. Okay, this I have taken from my mother, this I have taken from my father. If in the Prader-Willi syndrome, what is going to happen? The chromosome which is required, which is taken from the father, that is either deleted, which is the most common type of the imprinting disorder that may be present. Okay, what is another type of the imprinting? I will show you from your SOP book how imprinting can be present. I just came to know like that may be deletion. Here they have told the types, the biochemical basis of this deletion. There may be methylation, there may be some other like these biochemical reactions that make this part of the chromosome dysfunctional. Okay. Okay, what is the uniparental disomy? In the Prader-Willi syndrome, the chromosome from my father that was dysfunctional, that was deleted. Okay, or the other way, I have not received the chromosome from my father. I have received this 15 number of chromosomal pair only and only from my mother. So what is going to happen here? Again, there should be the presence of my father chromosome that is present. Okay. No, Dr. Hira, see here, this is the difference which I wanted to tell you. This is a uniparental disomy, but when father chromosome is not present, okay, this is Prader-Willi syndrome. This is not your when father chromosome that is not present, I have received only from my mother, right? So let us read it, then the things will become very much clear. Okay. What do you advise them about the risk factors? So this is, they are saying this is a case of uniparental disomy. Okay. She is a case of the Prader, a 16-year-old girl. She is a known case of the Prader-Willi syndrome. Secondary to the uniparental disomy, attends the clinic. During discussion, her parents ask you if she were to become pregnant, what is the whether the baby is likely to be born with Prader-Willi or not? Okay, will that be Prader-Willi or not? Will you advise him? It depends upon the sex of the baby. No, not at all. There is a problem in the 15 chromosome number. Okay, the baby has a 50% chance of having Angelman syndrome. The baby has a 50% chance of having Prader-Willi syndrome. You would expect the baby to be affected. You would expect the baby to be unaffected. Okay. Here they want to talk about the Prader-Willi syndrome. Okay. What is your answer here? What is your answer here? So what would you expect? Angelman syndrome, not at all. Recurrence risk means they want to ask you, is there any chance of this baby? Like, see here, this is the mother of the baby who is having uniparental disomy. Okay, so his both they are present from her mother. Okay, will this baby be a case of Prader-Willi syndrome? His baby. Will there be any chance of this Prader-Willi syndrome of this mother? You would expect the baby to be unaffected. Okay, this E is the answer here. Okay, you got this point? The baby would be unaffected. See here, what is Prader-Willi syndrome? Make it very clear. Otherwise, there will be no benefit of reading this clinical case. What is Prader-Willi syndrome? They told you in the Prader-Willi syndrome, we say we may have two situations. The one situation is that paternal chromosome that is deleted, okay, or paternal chromosome that is the father chromosome that is not present. He or she is having both from the mother. Okay. So she is having both chromosome from the mother. Okay. Now, what is going to happen when the baby is born? Okay, she is pregnant, right? She is giving her chromosome to, to her baby. This is a chromosome number 15. Both these chromosomes, they are of maternal origin. Okay. She is giving this chromosome to her baby. That is normal. That is of maternal origin. Is there any chance of this baby to be a Prader-Willi syndrome? now she will deliver this chromosome, okay, that is of maternal origin. We say whenever there is problem in the father chromosome, then there will be a chance to become a Prader-Willi syndrome, okay. So there will be no chance of her baby to be a Prader-Willi. Why? The baby is receiving chromosome from his mother, not from his father. So it will not be a case of Prader-Willi syndrome. Okay, I will tell you from this explanation. If they have told us here, see here, that will become a, okay, let us read it from the here. Okay, it's imprinting. You got this point or not? Please tell me so that I can move forward. You got this point or not? Hello. Not okay. I'm reading this imprinting, then you will come to know. Okay, let us do the second one, then we will read the explanation. Yes, but not that one about if received from the father. She's not, see here, where was the problem? The problem was in the mother chromosome. Okay. If I told you in the Prader-Willi syndrome, father chromosome either if it is present, it is deleted. But here they have told us where is the problem. It is not the problem of the deletion. Okay, for this, let me show you first the imprinting types and causes. Okay, here, see here, this is the imprinting disorder. Okay, imprinting disorder, I told you what is the definition. Now listen very carefully. We inherit two copies. We inherit two copies of the autosomal genes, one from our mother and one from my father. Okay, this is chromosomal pair that is from the mother, and one is from the father. Got it? For most of the genes, both copies they are active. The imprinted genes are different. Often arranged in clusters, imprinted genes are expressed only from the copy inherited from one parent, like uniparental disomy. Within one cluster of the imprinted genes, some genes are expressed only from the maternally inherited copy and are silent on the paternally inherited copies. Okay. Now see here, while others are expressed only from the paternal copy. Okay, this is the other thing which I was telling you. The process is controlled by the epigenetic factors such as the DNA methylation, which occurs if imprinted regions in the parent of origin specific manner. Here they have told us what are the different types of the mechanism of the genetic imprinting. That is a normal from the mother coming from the father. Okay, this is the process. This is a methylation. That is normal. Whatever is happening here, there is methylation defect. Here there was no methylation in the maternal gene, but in this case, see here there is the process of the methylation, a methylation defect that has happened in the maternal gene. Okay, paternal uniparental disomy, both alleles they have come here from the just one parent, right? See here, okay, maternal deletion that may be present, maternal mutation that may be present. These are the simple, do not go into much detail. These are the simple mechanism where imprinting can happen. Okay, there may be problem in the methylation. Why I'm telling you why this is because they may ask you in the question like methylation defect is present or not. See here, if we talk about the your Prader-Willi syndrome, these are the different types of the mutation that can be present. Okay, the most common one of them is a deletion of this copy of the father chromosome. There may be uniparental disomy, where instead of the father chromosome, the two chromosomes which are only and only derived from the mother. And the last one is the methylation defect. That is why I'm telling you there may be methylation defect and this one and this one. In the exam, you may get question which type is most common. This deletion is the most common. Okay. The next one is the uniparental disomy, and the last one is the methylation defect. Right? Clear up till now? I just have told you type of the imprinting disorder which we may have. Okay, here now they have told you about what are the like different. Okay, see here, these changes is reciprocal to the Angelman. We will not hypotony. Here they have told you about the features that can be present. Next, they will talk about the recurrence risk and the type of the mutation. In the recurrence risk, they have told here about your Angelman syndrome. We will read it after that. Okay. Now these are the defects we have come to know. Now I am going back to your task case where we will see is there any risk factor present or not. Okay. Now read the case that they have told this is a case of imprinting disorder that is due to uniparental disomy. So it means this is a case of Prader-Willi syndrome. This is from the mother chromosome that is normal, and this is uniparental disomy. It means she is not having father chromosome number 15. Here both the chromosome number 15 they have come from her mother. Okay, they have come from her mother. Parent problem is not with the mother chromosome to come, problem is with the absence of the father chromosome. So there is absence of the paternal chromosome. That is why this is a case of the Prader-Willi syndrome. You got up till now? Got this point? Okay. So now see here. Can her baby be a case of the Prader-Willi syndrome? In the Prader-Willi syndrome, this is the mother of the child. Okay. In the Prader-Willi syndrome, the problem is with the father chromosome. Either that is absent from the father, not coming, or what is the problem? There is absence that is coming, or if this baby has got chromosome from the father that is deleted. So there is no chance of the Prader-Willi syndrome mother to have a Prader-Willi syndrome baby. Why? That would again depend, just like the normal population. If her husband is giving this chromosome or not. Got this point now, Dr. Fariha? Is that clear? Dr. Friha, is that clear now, Dr. Saima? Okay, if please not clear, we can read it again. Okay, now, so you would expect what is the normal chance that is in the normal population, not with this mother. Okay, now let's see this next scenario. Following the consultation, you consider whether your advice would have been different if the Prader-Willi syndrome was a result of the chromosomal deletion. Now, this is the point. The same girl. Okay, she has two chromosomes, one that is from the mother and one that was from her father, but it is deleted, right? If a 16-year-old has a Prader-Willi syndrome as a result of the chromosomal deletion, what would be recurrence risk of the related genetic disorder? Now see, this is the girl which is having a deletion in her chromosome. Now these, she has got her chromosome from her mother or her father, okay? But now when she will deliver to this chromosome to his baby, that both are of maternal origin for this baby, okay? So what will be the chance? She may deliver one normal chromosome, okay, and one normal chromosome that is coming from his the baby's father. So this is a normal baby, okay. What is another chance? She is delivering a deleted chromosome to her baby, right? And one chromosome we are exposing the father is normal, one chromosome that is coming from the father of the baby. Now, I have 15 chromosome from my mother that is deleted. Okay, what is the chance of, what is this disease? When abnormal chromosome that is coming from the mother, what is the name for that disease? That is Angelman syndrome. Now, she was a case of Prader-Willi due to deletion from his mother. Okay, but now this baby has acquired deleted chromosome number 15 from her mother. So she has 50% chance of normal baby and 50% chance of having Angelman syndrome. Got this point? Okay, right? So this was the whole thing. Basically, now this is very interesting now. Like this, she was a case of paternal Prader-Willi syndrome, and she is delivering an Angelman syndrome. Okay, clear? Okay, the same thing they have told here. In the first, they have told the different sign and symptoms, very important. In the exam, they will not tell you this is a case of Prader-Willi syndrome. They will tell you the sign and symptoms of like what are the sign and symptoms typical of your Angelman and the Prader-Willi syndrome. Okay, I will read it very quickly. Prader-Willi syndrome are rare conditions affecting less than 1 in 15,000, and they have told Angelman syndrome is even rarer one. This is important for you to read. Like in your exam, you may get question. Angelman is more common. They may ask you Prader-Willi is more common. So every line of clinical case is extremely important. Okay, here they have told Prader-Willi is rare, but it is more common as compared to your Angelman syndrome. Okay, Prader-Willi is like there may be of all ethnic backgrounds that can have symptoms vary with the age of presentation with hypotonia in infancy, followed by excessive eating. Not the baby are not obese from the start of the birth. They initially they may be IUGR initially, they may be hypotonic, they may be NG dependent, okay, due to poor sucking reflexes. But after the infancy, they start eating, they have hyperphagia and become obese. Developmental of obesity and developmental delay may be present in the later childhood. Obstructive sleep apnea is a problem, hypogonadism and infertility. Angelman syndrome, it is usually, see here, they are happy babies, happy puppets. Okay, developmental delay is evident at 6 to 12 months. Ataxia, microcephaly, recurrent seizures may be present. Frequent smiling, laughter, excitability, and hand flapping fascinations with water and sleep difficulties may be present. These are the signs and symptoms we know. These are the results of the genomic imprinting. Okay, genomic imprinting we have come from to know from your SOP book the 5 diseases you must know their name. Okay, imprinting. They have asked in your exam what is the definition of the imprinting. You will see the all the scenario that may be present, but we must know which one is most common. Uniparental disomy is common, deletion is common, okay, your methylation is common. So see here, genomic imprinting definition they have told here. We all know that there may be like imprinting maybe from the father, from the mother, that will cause your Prader-Willi. Again, here they told the same thing I told you. If we get abnormal 15 chromosome from the father, that is the Prader-Willi. If get from the mother, that becomes Angelman syndrome. Okay, so the difference in between your Angelman and Prader-Willi syndrome is that we do not know what gene is defective in the Prader-Willi syndrome, like what, but the it is yet not known, not fully researched or discovered what gene is defective. But your Angelman syndrome, there is a gene which we must know for your exam, like UBA3A gene that is defective in your Angelman syndrome. Okay, and it is going to lead to all the phenotypic abnormalities which we may get here. Okay, now let's see here, here they have told you about the description, like why there are chances of having Angelman syndrome in the mother of the Prader-Willi, and why we do not have Prader-Willi syndrome in the mother of the Prader-Willi syndrome baby. Okay, so in reality, not many individuals with the Prader-Willi syndrome go on to the have child themselves, but there have been some rare exceptions in the females with this condition. Basically, the need is not to know whether they are having baby or not. The problem is that if the baby is a Prader-Willi syndrome, what is the chance of the recurrence? Okay, in your SOP book, they also have told about the chance of the recurrence risk in your for your Angelman syndrome. We also will read that. Okay, the same explanation they have told here, which I have told you. Nothing more than that. Okay. Okay. Now we will go to your SOP book, and from that I will read your Angelman syndrome and the recurrence risk. Okay. See here the same point. There is a chromosome number 15. This one defect that is present. No, not this. Yeah, this one, UBE3A, this gene. See here, paternal uniparental disomy deletions, they are more common. Now see here, the defect that was methylation in your Prader-Willi syndrome, but here they have we in your Angelman syndrome, the gene mutation that is also known. What is that gene mutation? This is UBE3A gene mutation. Loss of functional mutation of the maternal allele of UBE3A gene. Okay. The third type, okay, recurrence risk. Let us see here. Yes, they have told here. These abnormalities are reciprocal to seen in this Prader-Willi syndrome. These mutations, these are usually inherited from the probands of the mother. Okay, in which case the risk of the recurrence is 50%. Most other causes occur de novo and have a low recurrence risk. Okay, here they have told you if there is no mutation of this gene, then the recurrence risk is 50%, right? Angelman syndrome causes severe developmental delay. There is definite behavior phenotype. They have told you microcephaly seizures may be present in more than 80% of the cases. Some children with deletions have fair skin and hair color due to the presence of pigment gene near the Angelman syndrome. Molecular genetic testing is by methylation testing followed by the microarray for deletion. Please do remember. See here they have told us what are the genetic testing. Very important. They have given me many, but do remember for the genetic testing. Okay, when we want to know how many number of the chromosomes present or not present, then we go for karyotyping, like your chromosome, your Turner syndrome X0. We see a sex chromosome both present or not. We go for karyotyping. When we want to know is there trisomy 18, 21, this one we go for karyotyping. When we have to see the deletion, when we have to see the micro deletion, when we have to see the duplication, we prefer your microarray testing. We will read that with this one with the questions. Okay, we go for microarray testing. You will see this is the preferred modality of the genetic testing when we want to know deletion, micro deletions, and duplications, right? When we want to know which, like I know this is most likely a case of my cash 22. He has shown me all the features of the third and the fourth Brinkel arch absence or defect. Okay, for that, when I am suspecting there is a problem in the chromosome number 22, then fish will be my modality of the choice. Do remember this deletion, microdeletion, we can come to know about by the fish analysis and by the this microarray analysis. And now the preferred modality for all this one is microarray. Okay, this is for your like exam questions. You just need to know this one is the preferred and the most advantageous modality of the genetic testing, microarray. I will tell you how do we perform this microarray. Okay, the third imprinting disorder, that is the Beckwith-Wiedemann syndrome. We know all the features that mm, difference between, yes, I will tell you, Dr. Hira, we will discuss them when we will read the recalls, then it will become easy for us. Okay, I will tell you. I just covering and now the imprinting disorders. Okay, now see here for your exam we must know. Now see the difference in the Beckwith-Wiedemann syndrome. Okay, I will tell you, Doxima, we will do it when we will do the recalls. Okay, with the questions we will do. And let me cover this imprinting disorder. The third imprinting disorder for your exam question. See here in the Beckwith-Wiedemann syndrome, If we talk about deletion, have they told about deletion any point here? No, that is the decreased methylation, which is 50% of the cases. Okay, increased methylation, that is in the 5% of the cases. Very important to know. Loss of functional mutation on the maternal allele. Okay, that is of the CDK and 1C, that is 5%. This paternal uniparental disomy at chromosome number 11p15. This is 20%. Now see here, which one is most common? Whenever we talked about Angelman and Prader-Willi syndrome, the problem was in the 15 chromosome and deletion was most common. Beckwith-Wiedemann syndrome, that is also a type of your imprinting disorder, but here the most common cause is decreased methylation. In your Angelman and Prader-Willi, methylation was just 1% of the cases. Rather, in your Angelman syndrome, we have loss of function of this chromosome. We need to memorize this chromosome, and also for your Beckwith-Wiedemann syndrome. Okay, you got this point? And it is a reciprocal of the Russell-Silver syndrome. Here the maternal allele, that is problematic. In your Russell syndrome, there will be methylation defect. Paternal allele is problematic. Both usually comes with, you see, one Russell Silver is coming with your IUGR, Beckwith-Wiedemann, that is coming with the obesity, right? So hemihypertrophy, that is present in your Russell Silver, hemihypertrophy, that is also present in your Beckwith-Wiedemann syndrome. Here methylation defect is the most common defect, but the previous two, methylation was not the most common. That was just 1% in your Prader-Willi syndrome. Okay. Now we have discussed the imprinting disorder with your, and that case number 21. Okay. Which testing that is important? See here, testing for the imprinting disorder. We know which one for the deleting testing, microarray, that is the preferred modality of the choice. Okay, DNA sequencing, that is not the preferred one. That is also going to test like where is the problem in the gene that is present. Okay, methylation testing, that is also not. See here, using techniques such as the methylation specific PCR is often a first line testing for the imprinting disorder. It is capable of detecting methylation defect, uniparental disomy, and deletion, since the latter two results in the altered DNA methylation pattern by removing one of them. Now for the deletion, they say microarray is the preferred modality of the choice. Okay, but the methylation defect that is present in your Prader-Willi syndrome, we can also do that, but after your microarray and this fish analysis. Okay, so now we will move to the next question from your clinical cases. Right. So this was all about imprinting disorders. We need to know which testing for deletion, your microarray is the modality of the choice. There may be methylation defect, that is just 1% present in your Prader-Willi syndrome. We need to know which genetic defects they are present or not. Okay. The next case, that is the easy one, your Down syndrome. Okay. Jennifer, a baby girl who is born to the healthy, unrelated parents, 36 hours of the because of the floppy baby. On examination, she is well, but in addition to the hypotonia, they have told me brush-filled spots are present, single palmar crease is present, and increased sandal gap. Okay, what chromosomes are sent? Chromosomes are sent means that a karyotyping has been done. If Jennifer does have Down syndrome, the most likely cause of result, simply they want to ask you which one is the most common type. We know there are three types of the mutations we do have in chromosome 20 in Down syndrome. That may be trisomy, that may be mosaicism, that may be translocation. Which one is most common? Okay, see here, is that 45x0? Not at all. That is an aneuploidy. Okay, trisomy 21 is also a aneuploidy, but it is of autosomes. Chromosome number 21, not of your sex chromosome, so that is paternal. 45, okay, 47 XX plus 21. Very good. Like add the chromosome, she is a girl, so she's an XX. 21 trisomy, that is most common, and chromosome number instead of 46 has become 47 now. Okay, from your SOP book, we will see how to write mosaicism. This is the trisomy. How to write the mosaicism karyotyping, we will read after that. In Down syndrome, the most likely cause of the additional chromosomal material is inherited translocation, maternal non-disjunction, mosaicism, or paternal non-disjunction, spontaneous translocation. Which one is most common? If we talk about the trisomy 21, okay, B, yes, do remember. We always think like there is maternal non-disjunction. Yes, that is the most common cause. But in some cases, we will read in the explanation they have told. In some of the cases, even paternal non-disjunction may also be present. Okay, there may be translocation, may be present spontaneous. There may be some de novo cases, mosaicism that is also present, but maternal non-disjunction, that is the most common type. Okay, the family come back to see you. Both parents have been tested and shown to have normal chromosome. Okay, so the mother is now 35-year-old. What is the risk of having another affected child? Is that 1%? Is that 1% plus age adjusted risk? 2.5%, 25, or which one is the answer? Yeah, B is the answer here. Okay, I will show you in the SOP. They have given a table where different translocation type, like if there's translocation between 2021 of the child and the parents also have this translocation, then there will be 100% chance the next baby will be Down syndrome. I will show you a table. Okay, there is the concerning screening. Are the following statements are true or false? Okay, we all know about the screening test of the Down syndrome. After 16 weeks, screening is not helpful and parents should be offered diagnostic testing. What are the screening testing and what are the diagnostic testing for the Down syndrome? Okay, we know the screening tests that are done on the mother during the pregnancy after 16 weeks. Is that true or false? Is this true or false? Dr. Hira, is that true? That is false. We can go for testing even after the 16 weeks. Okay, amniocentesis can be performed in the first trimester. What is the typical time period for the amniocentesis? That is after 16 to 20 weeks. Okay. CVS chorionic villus sampling can be performed from the 10 weeks of gestation. Yeah, usually from 10 to 14 weeks. Okay. The combined test will identify more than 85% of the cases. Combined testing, what do you mean by the combined testing? That is done by ultrasonography to look for the nuchal translucency and pregnancy associated proteins, which are usually raised in the mothers of the baby who are having Down syndrome. See here that just we need to memorize they have more than 84% chance to identify, not more than 90%. The risk of miscarriage with the amniocentesis and the CVS is a similar, yes. We usually keep in our mind that like there are more chances with the amniocentesis for the miscarriages. No, not at all. The risk that is equal for both of them. Okay. Now, any ambiguity in this question? Like nothing very much special or difficult. Okay. From this explanation, what we got to know, see here, the problem is that here we will learn a new thing that B is false. Yes, B is false. They said in the first trimester that is performed from 16 to 20 weeks. In the second trimester. Okay, here they have told you like how a zygote is formed. Before fertilization, there is also a process of male and female germ cells. They also undergo the process of the meiosis. There are two divisions, the first meiotic division and the second meiotic division. In the exam, they may ask you non-dissection is going to happen in the first meiotic or in the second meiotic. So the answer for that, it is usually in the first meiotic division. The paired chromosomes, they get separated and they get brought to transfer one from the mother and one from the father. Okay, non-disjunction, that is the most common cause. See here, I will tell you this is not only trisomy 21 occurs due to maternal non-disjunction in 88% of the cases and paternal non-disjunction in the 8% of the cases. Okay, in your SOP book, they also have told you why this, which phase of the meiosis this is going to happen. That is going into your anaphase. That is known as anaphase lag. Anaphase is the phase of the meiosis that is the longest one, that is having the long duration. So the most chances of non-disjunction, like not getting separated, they usually happens in the anaphase. Okay, which is known as the anaphase lag. And anaphase, why it is more common in the maternal non-disjunction? The anaphase of the meiosis, that is longer in duration in the female as compared to the male. Okay, so that is why this non-disjunction, like it is not getting separated from one another and going to the moving to the opposite poles. So that is when these both two chromosomes, they will get entry into the fetus. So this chromosome number, like at that level, at the number of this 21, one will come from the father, and this non-disjunction, which are not separated, both will go to the baby, and this baby at this point will have three chromosomes. Okay, in the mother, this phase is longer one. So here, the maternal non-disjunction, that is having 88% chances of getting this one, Down syndrome baby. Okay. Mosaicism. What is mosaicism? This is the most common cause of Down syndrome. Mosaicism is that some cell will have normal chromosomes and some will have trisomy. Okay, so here the phenotype will be milder as compared to the non-disjunction chromosome babies, right? Translocation, very important point they have told in these lines, your exam questions. We have, what is translocation? This is the chromosome, see here. Okay, this part of the chromosome, it is translocated here, and its part, it has come here. So there is no gain, no loss. That is known as a balanced translocation. Okay, whenever there is balanced translocation between two chromosomes, the person usually will not present the disease or manifestation or genetic abnormality manifestations. Do remember, there are chances there will be disease expression in the offspring of this balanced translocation person. Whenever there is balanced translocation, like there is no gain or no loss of the genetic material, the person will not represent the disease, but the baby of this balanced translocation person will have unbalanced translocation, will have not 100% cases, but if the baby of this person has unbalanced translocation, the disease will become more appear. That will be more dangerous to have unbalanced translocation in this person. Okay, so translocation may be in different genes, maybe between 21 and 21, maybe chromosome number 21 and 14. Why this, knowing this translocation is important? That will tell you about the recurrence risk. If there is translocation between 21 and 21, there are 100% chances of the next baby to be a Down syndrome baby. Okay, and if there is translocation between 21 and chromosome number 14, there will be less chance, maybe up to 4%, maybe up to 2%. Okay, now read this line, very important. In some cases, a translocation and subsequent cell division lead to a cell with the correct amount of the genetic material, which is known as the balanced translocation, where genetic material is gained or lost, which is known as unbalanced translocation. That becomes lethal abnormality that will lead to presence of the genetic syndromes. Individuals who carry a balanced translocation will be normal but have an increased risk of offspring with an unbalanced translocation. This is your exam question. Okay. Now, here they have told you about the Down syndrome. We all know very much features of the Down syndrome. The main point here is basically that how to do the screening of Down syndrome in the UK, right? So trisomy 21 screening, that is done 1, 2, 3, and 4. Four methods. The combined test, okay? These, how you will memorize them, which test is going to perform in which week of the gestation, okay? So your combined test, that is usually done from your 11 plus 2 weeks from the 11th week of gestation, okay? We usually perform it between 14 to a week of gestation. So we can say 11 to 14 weeks of gestation, we can go for the combined testing. What are combined? Ultrasound to look for the nuchal fold of the child, the blood testing which is going to assess pregnancy associated plasma protein A, and free beta HCG. Okay, the ultrasound and this blood test, they are combined with the maternal age to give an estimated risk. The combined test picks 84% of the babies. Now see here in the exam, in your question they have asked you that it was more than 90%. No, that is up to 84% of the cases. Okay, then is a quadruple test. Now see here, from 11th week of gestation we can perform the combined testing. When the mother is coming decide too late or coming to you with very late, then we go for this quadruple testing. Okay, these are the four tests which measures alpha fetoprotein, beta hCG, inhibin A, and estriol levels. Okay, and use the result in combination with the maternal age and gestation to calculate the risk of Down syndrome and spina bifida. Usually we will talk here about the Down syndrome. In the exam, they may ask you what four tests which are including. They may give estriol, they may give diestriol or other hormones. So need to memorize all four these features. Okay. Women who are at risk of the Down syndrome greater than 150. Okay, okay. Next one is the CBS, that is performed from 10 to 13 weeks of gestation. Okay, there is 1% risk of the miscarriage. Okay, amniocentesis, that is usually performed between the 16 and 20 weeks of gestation. Okay, there is also 1% risk of the miscarriages. Both is the same for both. And after the 20th week of gestation, we can go for the anomaly scan, where we can see the structural abnormalities of the baby and chromosomal abnormality. Definitely when there is saddle sign, that we can say that is most likely to be associated with your Down syndrome. Okay, now we will go to the SOP and we will see what they want to tell us about the Down syndrome. Important for your exam, what is that? For your Down syndrome, see here, very here the same question they have told you about the karyotyping. Remember, in your FOP examination, FOP clinical cases, they have told us if we want to know, like the early test was qPCR, quantiferon PCR, that was going to tell us results within 3 days, within 2 days. Okay, and we also measure we also go for karyotyping, but the karyotyping results usually comes after 3 or 4 weeks. Okay, what are the risk factors? Again here they have told you, but this table, that is extremely important. We need to know which type of the test we want to do. Okay, type of the translocation, the risk of having a child with Down syndrome to the parents carrying the most common balanced Robertsonian translocation involving chromosome number 21. Okay, whenever there is balanced translocation, that person will not show the disease, but the chances of their having a disease baby they are that are increased. Okay, whenever there is translocation between the chromosome number 14 and 21 or 21 and 22, okay, you will go for the first thing is that whenever we find translocation between in the baby's chromosome, we check for the mother and the father chromosomal translocation. Okay, in that case, see here, if the translocation that is present in the maternal chromosome, there are 10% of having the next baby with this Down syndrome. If this translocation, balanced translocation that is present in the father chromosome, there are 2.5% chances of having next baby with the Down syndrome. If there is translocation in the baby between 21 and 21, either that translocation is present in the mother and also in the father, mother or the father, there are 100% chance that next baby will be Down syndrome. Okay, whenever we find translocation in the newborn, in the baby, we go for karyotyping to look for the translocation in the parents. If any parents they have translocation, we want to see which chromosome is translocated. If there is translocation between 20 and 21, the next baby is 100% to be Down syndrome. If there is balanced translocation between 14 and 21 or 21 and 22, there are chances different for the mother and different for the father. Okay, so this table that is important. Now see here in this question, in this like they have told you the same thing. If we want to know about the chromosomal testing, we go for karyotyping. The test of the karyotyping, it usually comes after 4 weeks. The fish analysis are the array analysis that is done to look for the deletions. Okay, not for the translocation. Here in your SOP book, they have told you what are the advantages and disadvantages of the microarray. We will do it with your questions. Okay, so for your Down syndrome, we need to know that is a aneuploidy. What are the translocations? What is the difference in the balanced and unbalanced translocation? Why in the maternal non-disjunction that is common? See here, this is the anaphase lag, that is the longest phase, and it is moving very slowly. That is, it's moving slowly. That is why it is the long phase in the female, right? How they will write about the mosaicism? See here in the mosaicism, some chromosomes they are normal, so it is 46 normal chromosome in the female, and some are having trisomy, that is what 47 chromosome XX plus 21. This is mosaicism. In the mosaicism, they will write karyotyping like this. Some cells they are normal and some cells they are abnormal. So the karyotyping will be written with the normal and with the abnormal. Okay. Now see here in the mosaic Turner syndrome, some cells have Turner problem and some cells have normal karyotyping. Right? Okay. Now we'll move to the question number, task case number, the next case. There is a case number 24. Okay, see here, that is a recurrence risk conditions with a known inheritance. They usually will not ask you what is normal, autosomal dominant, we know, autosomal recessive, we know, X-linked recessive, we know. Okay, now see here in the exam, you will get questions like, you see a 9-month-old girl of the African descent who has been referred as she's coming to you with the dactylitis. That is a known case of like, sorry, I will read it. You see a 9-month-old baby descent who has referred to you because of the painful finger swelling. Your diagnosis dactylitis and suspect underlying sickle cell disease, which is confirmed by the electrophoresis. So this is the child who is coming to me with a sickle cell disease. Okay, that is an autosomal recessive disease. For any disease to be autosomal, there are 100% chance of the parents of this baby to be a carrier. Okay, so if the both parents they are carrier, they can give birth to a baby who is having autosomal recessive disease. Okay, now see what they say. Her mother, she has always been very well. It means we are not suspecting this is a case of carrier or like, okay, she may be a case of carrier, but she's always been normal. You have electrophoresis result of the girl's father, Adams. Okay, on the hospital computer system that tells you he is not a carrier. If he is not carrier, how this is a case of autosomal recessive disease? Adam tells you that Brenda has recently fallen pregnant again. So we have a baby. See here, we have a baby girl who is a case of the autosomal recessive disease. It means both her parents should be 100% normal. Okay, okay, the both parents should be a case of the carrier, right? But now they say there are no chances. Mother is quite normal and father's electrophoresis report that is quite normal. So, what is the probability that Adam and Brenda's unborn child will have a sickle cell disease? So, tell me what are the chances? What is the probability? What is the answer? Is it 0%, 25%, 33%, 50%? What is the chance? Dr. Varda, what is the chance of this getting a disease? Father is normal, 25%. Okay. Mother is a carrier. So, father is normal. Now tell me, what is the chance? They told me mother is quite normal. Mother may be a carrier, may or may not be carrier. Okay. Mother is a carrier. Father, they told me father is quite normal. What is answer here? The one we see here, F is not present, Dr. Hira. E, there is no F in the question number. Oh, sorry. Okay, I was looking. Zero, I guess. Dr. Varda, why you said that is 0%? The yes, the chance 0%. That is the correct answer. Why? See here. The one problem, this is basically the mother is a carrier. The yes, mother is a carrier and father is normal. So, what is the chance of having a diseased baby? That is just like a normal population. That is 0%. Why? Father is not having any. No, father is not. They have clearly told you. Father is not a carrier. So, see here, they usually talk about the practical. This may not be the biological father of this baby. They have, see here, in like in their population, we have read many questions that may not be the biological father. In the explanation, the one thing they have told here, non paternity is very common and occurs in 10 to 15% of the UK population. Okay, this one is the point that this father may not be the biological father of this baby, or another point is that this baby may have de novo mutation, like where the mother is normal, father is normal, and this baby may have a de novo mutation. So that in that case, that the chance is just like the normal population. If we talk about this couple whose father is quite normal, the mother may or may not be a carrier. So there is no chance of having disease in this baby. Autosomal recessive disease will be apparent when the father is a carrier, when the mother is a carrier. If only one parent is carrier, then the baby will not have the disease. He may have disease just by chance, that may be sporadic mutations, de novo mutations. Okay. So, no, this is not, they are not talking about the carrier. They want to ask you about the disease. So there is 0% chance of this baby to be a diseased. Okay. Okay. Now, the next question, a man has a X-linked monogenetic disease. Okay. So this is a man who has monogenetic means that is a single gene that is defective. Okay. With complete penetrance, it means if it is present, it will show all the phenotype of the disease. Looking at the family tree below, what is the risk of the daughter having his disease? Okay, so let us see risk of the daughter having this disease. This is a father of the mother, a baby. Okay, this is a father who has X-linked monogenetic disease, right? And this is the mother of this baby. We suppose that she is normal, right? Now, now they are asking about the girl to be diseased. The girl to be diseased, what is that chance? This is a father X that is monogenetic disease. If it is present, she will get a normal X from the mother. This will be a girl and this will be a girl. Okay. So 50% if it is dominant gene. See here, what do you mean by dominant gene? Dominant gene means if for a disease to be dominant, just one gene that is required to express the disease. Okay. What is the recessive disease? We need mutations at two genes to be expressed for the disease. Okay. So if that gene, if it is dominant, the every girl of this child 100% will be diseased if it is a dominant gene. Okay. Yeah, all girls will be defective and it will be 100%. Okay. All boys will be normal. Yes. So the same thing they have told here in the explanation. They have told how to look at the mutations of autosomal dominant and autosomal recessive. What are the genes which are, what do you mean by dominant and the recessive? For a disease to be dominant, only a single gene that is required to be mutated, and for the recessive, we need two genes to be mutated for the expressions of the disease. Okay. Now in the question one, they have told the same thing which I told you, like if that may be a non biological father of that baby. Okay. Or that may be a new mutation that may be present. No, see here, this is not X-linked or this one, and you just make, they will not ask you about this is X-linked dominant or recessive, but see here, the point here is not about the girl and boy. Make a pedigree. A man has a X-linked monogenetic disease. X-linked monogenetic means this man's X chromosome that was defective and this was going to present the disease. Okay. This X-linked monogenetic disease can be, just 1 minute. Okay. That can be autosomal dominant or autosomal recessive. Okay. Now see here how they are saying this is the genetic family tree. What is the risk of the daughter to be having this disease? They told me this is an X-linked. They have not told me this is autosomal recessive, sorry, X-linked dominant or X-linked recessive. Okay, if we talk about Dr. Zahra, the point here is that that may not be the genetic biological father of that baby. Okay, in their society, we have read many questions that may be the biological or non-biological father. So see here, it means the first baby is from another couple. The mother is same, but the father is not the same. The second baby, like she is pregnant, not from the father of the first one. Okay, now she has a new partner. Okay, you got this point? These two siblings, they are not from the same father. In the UK population, they have told you like say 10 to 15% may not be the biological father of that baby. Okay. Now see here, this father will have 100% chance of having if the gene is dominant, then 100% of the daughters will be affected. That will be your X-linked dominant disease. Okay. Right. Okay. These are the simple explanation we have like your about your X-linked dominant or recessive. Right. Now see here in the question 2. As a man, the father has only single copy of the X chromosome and therefore carries one copy of the mutated genes and no other copy of the gene. His wife carries two normal copies of the gene. Each parent pass a single chromosome to their progeny. Mother always supply the X chromosome. There, the sex of the offspring will tell you the sex chromosome father has supplied. Okay, the father will supply the this defected X chromosome. Son always receive the Y chromosome from their father, and daughter always receive the X chromosome. Their daughter will therefore always inherit a mutated copy of the gene from the father. If the gene defect is dominant, then there is definitely 100% chance of the daughter to be affected and their son will be normal. If the gene defect is recessive, she will not receive the disease. This one is the thing which I want to tell you. They just have mentioned if it is dominant, then definitely it will be disease. If it is recessive, then it will not be disease. Why? For the recessive, we need two mutated copies for the expression of the disease. Okay. Okay. So now these three are questions for your clinical cases for genetics. Now we'll move to the recalls of the genetics. With that, we will read some topics from your SOP book. Just 1 minute, please. No. Okay. This is the first question from your task genetic testing. Pathophysiology of the Duchenne's muscular dystrophy. This is deletion, point mutation, frame shift mutation, missense mutations, and translocation. Which one is the answer? Is that correct answer? See here, from this point, you will come to know we always read Duchenne's muscular dystrophy, that is an X-linked recessive. Okay, coming into the boys, no. In the test examination, they will ask you, is this due to deletion? Which type of mutation that is present? So see here, DMD, the most common mutation in the DMD is the deletion. Okay, one or more exons. So they may give you many questions with which one point mutation, this one. The most common is your deletion. I will tell you evidence-based answers for that. Okay. Now here you will come to know what is a diagnosis, but here we have to learn how like we can get how which type of questions after reading the diagnosis of this one. You will tell me what is the diagnosis. Baby delivered floppy with central and peripheral hypotonia, need activity resuscitation and mechanical ventilation. His mother had muscular problem with slurred speech, and maternal grandmother had cataract. History of the decreased fetal movements and polyhydramnios. What is the likely cause of his presentation? What is diagnosis? Very easy. We have done it in your POP examination. Clinical cases. What is diagnosis here? Muscular dystrophy. Dr. Friha, what is diagnosis? Dr. Saima, what is diagnosis here? That is myotonic dystrophy. Now I will tell you, for your myotonic dystrophy, they may ask you three type of questions just from a single paragraph. Okay. What is the anterior horn cell defect due to SMN? Which is this disease? Anterior horn cell defect due to SMN1 gene defect. That is, yeah, that is your SMA, spinal muscular atrophy. Infections during the third trimester. If they want to ask you about the torch infections, transplacental acetylcholine antibodies. Is this a case of myasthenia gravis? Not at all. DNA segment triple repeat. Is that the correct answer? Is that the correct answer here? B is the correct one. Okay. Now see, you will see from your, if I have collected it here. Okay. This is the myotonic dystrophy. Okay. Now in the exam, you may get question. They will give you a scenario about the myotonic dystrophy. Whenever they will talk about the polyhydramnios, decreased fetal movements, mother is having a problem like she's having mask face, she's not smiling, right? And there is myotonia that is present, cataract that is present. This is a case of the myotonic dystrophy. You need to know how to make diagnosis of myotonic dystrophy. They will ask you, is this a case of autosomal dominant or recessive disorder? Is this a case of X-linked recessive, X-linked dominant? This is an autosomal dominant. 1 point for your question. That is by the triple repeat expansion. Okay. CTG repeat that is present. How many diseases which are known as like to be anticipation? Okay. They may give you a question. Is this a case of genetic anticipation or not? The greatest risk of the expansion is when the condition is passed from mother to the child. This 1 point. This is your exam question. And autosomal dominant, triple nucleotide repeat. What are other diseases with your triple nucleotide repeat? One is, Dr. Varda, do tell me what are diseases? One is your myotonic dystrophy. The second one is your ataxia telangiectasia. The third one is your Huntington's chorea. These three diseases, they are triplet repeat expansions. And these are an example of genetic anticipation. Okay, this is known as genetic anticipation. You may get three types of question from this paragraph, right? Okay. Now the next question. Yes, fragile X2, exactly. The next question. Mechanism in the microarray comparative genomic hybridization. What is the mechanism in microarray comparative genomic hybridization? Any idea about this microarray? Okay, let me first tell you. They are saying it is going to detect the deletion of all chromosomes. It is fluorescent probe DNA in comparison with other DNA. Specific segment of the DNA detects single gene defect, detect number at specific locus. Okay. Any idea about all these ones? Fish is the fluorescence. Here also we use fluorescence probe. Basically, fluorescence probe also used here. I will tell you what is the technique. Okay, first of all, this is basically the technique. Okay, chromosomal technique. Okay, now I just wanted to tell you this tray is known as array. Okay, this is your microscopic slide, right? Where we have a number of samples. Okay, they have placed it here like this is the chromosome number 1, 2, 3, 26. These are the number of the chromosomes are they have made a sequence. Okay, here all they know the known DNA sequencing they have placed here. I will just tell you what is the method basically. By this method, we want to know where there is deletion or duplication that is present, right? What they do, they can take a control sample and they take a disease sample. We can say that that is a sample where we know deletion is present or duplication of the genes is present. So these are not the cancerous one. See here, these are deleted genes. Let us talk about the deleted gene samples. Okay, I have taken two samples. One is the control, that is the normal, and another one that is disease, like where I am suspecting the deletion of the genes that is present. I have made a tray where I know what is the sequencing of all these genes here that is present. Okay. Now I have taken the DNA of these patients. One is normal, one is abnormal. I have what is a process where DNA is converted into the RNA, that is known as the transcription. Okay, I have done the transcription. I have taken out your messenger RNA from this DNA. Okay, again that has been converted into your comparative DNAs. Like what was the way? Basically, they want to ask you like their DNA that was present here, it may come combine with this DNA. So first of all, we convert it into messenger RNA, and then we do reverse transcription, where this messenger RNA that is again converted into your DNA. This is not the job. We do not need much detail of this process. Just we need to know what we get: control DNA and diseased DNA. Control is normal and diseased is abnormal. Then we mix both these. Okay, the mixing of this normal and abnormal in one sample, right? Now we make a tray on your microscope slide where different sequencing that are present, right? These are fluorescent basically. I will tell you here they basically slightly a difference in the coloring that was done. In the exam you may get question which one is green and which one is red. Okay, now what this do after the mixing these normal and abnormal, they are going to wash it. Why wash? They say here I have a known sequence of the genes that is present. Okay, this gene which is the mixing, I will put a drop of this mixture here, 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 and here. Okay, what it will do, it will detect where deletion is present. When deletion will be present, it will give green fluorescence. Where duplication will be present, it will give me a red fluorescence. Where there will be no deletion or duplication will be present, it will give me a black color of this tray. Okay, why they have done for washing here? See here, after mixing it, I allowed it to be hybridized. What do you mean by hybridization? I told you there is a sequence, the unknown sequence of the gene that I have put here. Okay. After mixing it, it will detect where deletion is present. If in this known gene sequencing, I'm knowing that deletion is present, when I mixed this DNA here, the part of this mixture that is deleted, I will tell you. Just let me complete this one now. Okay. It will go to this deleted part and it will give me a red color. It will go to this duplicated part and it will give me a green color. Okay. Now I will show you. Basically, you will get your exam questions from your SOP book. Here, the red and green color that was different. Okay, where I have collected, I have seen here from from YouTube and from the Google, they have given the different ways. Like they have given the normal with the control with the green color and abnormal with the red color. But we get question from your SOP book where they have told us, like if we talk about chromosomal abnormalities, we use this array from the chromosomal abnormalities. We will see the duplication and the deleted genes, right? So let us read that. Okay, now see here the patient label DNA. Now listen carefully, what was that? Okay, I have made a slide where I know I have put some known gene sequencing on this slide. Okay, I have taken two samples. One is control sample and one is abnormal, deleted or duplicated gene sample. Okay, now see here. Array sampling is relatively new technique which is preferred now, right? Where we use two techniques, patient DNA to the normal control DNA. Okay. In the CG, the patient DNA is labeled as green. This is the difference from that picture. They here say the patient DNA that is labeled as green. This was the patient DNA. The control DNA that is labeled as red. Okay. Now, what we do, the thousands of the different probes, fragments of the DNA which bind specifically to the regions spanning the whole genome are immobilized on a slide. This slide with this tray that is known as array, I have made a known gene sequencing over here. I know like this is a gene chromosome number 1, this is the chromosome number 15, this is the chromosome number 10, and in this chromosome this gene sequencing that is present. What is the gene sequencing? If we talk about, if we go to your DNA, see here, we know there are two strands of the DNA, primer 5 and primer 3. This one are the nucleotide. Okay, the T is going to combine with your thymine, is going to combine with your adenine, your guanosine that is going to combine with your cytosine. This is the gene sequencing. I know at this level this gene sequencing, let me talk about, I have a sequencing of T, A, C and G. This sequencing is present. Okay, if there is any deletion of this TAC gene, any deletion of this gene is present at this one, this will go here and it will give a fluorescence of which color? Maybe of green color. Okay, my patient DNA that was green colored, this is my known sequencing of the gene that is present. Now I have mixed it, they both have combined with each other, they have hybridized. Okay, here I also have a known sequencing of the gene that is present. I put it here drop by drop, whether it will give me a red fluorescence, whether it will give me a green fluorescence. Okay, where there will be green fluorescence, it will tell me this gene is deleted. Okay, now see here. Here the array has detected as a deletion at chromosome number 7. You got this point or not? If not, tell me very clearly. This is something that like we usually do not go for these things. We just need to know why we are going for the fish, or okay. Here, just we need to know the patient DNA they have labeled as green and the normal is as red. Now they have made a tray, okay, that is of this where they have known sequencing of gene that is present. We will mix this patient and control, then we will wash it, and then we will put it on the slide. We will allow them to hybridize. Okay, now see here they have made these rings. Okay, whenever there is deletion, it will give me a green fluorescence. If there is duplication or normal, it will give me a red fluorescence. In the your test, they will ask you which one is green and which one is red. Okay, the array is immersed in a solution containing equal proportion of the fluorescently labeled test and control DNA, allowing green patient DNA to compete with the red control DNA to hybridize with each of the probe. Add probe where there is deletion, that is the lower patient group, the array appears red. Okay, and where there is duplication, the array appears green. These 2 points you need to know for your exam. You got this point? The array is scanned with a high resolution camera and we can see where is the red one and where is the green one. So, okay, now your exam question, what we can see with the array and what we cannot see with the array. Now see here, we can detect the deletion, we can detect the duplication on your array analysis. Okay, array CGG is typically able to detect deletions and duplication larger than approximately 50,000. There is resolution more than 100 times higher than karyotyping. They may ask you which one is advantageous. This array is advantageous, okay? And it allows the detection of the micro deletion or duplication as well as other large chromosomal copy number abnormalities. This one is the disadvantages of this array. What is that? It cannot distinguish unbalanced rearrangements caused by the different mechanism. Like it cannot detect unbalanced translocation. This is the disadvantage. This is your exam question. You need to know that this is the preferred modality, but it cannot assess unbalanced translocation. Why? See here we have hybrid. We do it hybridization. What do you mean by hybridization? This one thing I have placed here, and this probe which is fluorescent, I'm going to make it to be hybridized with this one. Okay, so whenever there is unbalanced translocation, it will get attached when there is balance between these two pair of the adenine and thymine. Whenever there is unbalanced translocation, this array will not detect it. Okay, this was your micro CGH array. Now next is coming the fluorescent hybridization. Now you will concentrate what is the difference between this fish analysis and between your array analysis. Okay, what is fish? Now basically we see the basic pathology between both these two is the same. Okay, here I am going to hybridize, right? And here I am also going to hybridize. What do you mean by inside two? Here is also fluorescence, here was also fluorescence, here is hybridization, here is also the main mechanism is hybridization. So what is the difference in between? Okay, in situ, right? So what is the difference between this one and this one? The mechanism is both here the same. The problem see here is that I know where I have to place which place. Here I don't know which, like whether the problem was in chromosome number 11, whether the problem was in chromosome number 22. Okay, I have made a tray where I have placed gene sequencing of chromosome number 1, chromosome number 22, 3, and up to 22 autosomes and 23rd pair of the sex chromosomes. Okay, I don't know where is the problem, but I know what is the sequence of the 22. I know what is the sequence of the 23 chromosome. I have placed a solution here. Okay. When after I place a solution, I got my fluorescence at the chromosome number 2. So I made my diagnosis that there is deletion at the chromosome number 2, which have come with these phenotypic abnormalities. Okay. From that, I have come to make my diagnosis. Like, I do not know the clinical features which were present. There was some abnormalities was present. I put a solution and I come to know there is a deletion of chromosome number 2. Okay. What is the difference in the fluorescent in situ hybridization? I have clinical features of Williams syndrome. Okay. And I have made one probe where, see here, this is the DNA sequence of this patient. Okay. What, first of all, what we do? We denature, we separate these strands. This is the strand DNA of the patient. I have separated it. The one I have got here, this one is this one. Okay. Now see here, I know the diagnosis clinically. I am suspecting this is a case of CASH 22. So I have taken the chromosome number 22 of this patient. I have separated the DNA of the chromosome 22 of this patient. I have taken a band of 22, a strand of 22 chromosome here, right? Now, I have made a fluorescent uh, probe or fluorescent strand by myself. This was a patient strand. I have made a strand of by myself that is complementary to this chromosome number 22. Okay. Now, if I allowed it to be hybridized, I put it with this one. If it gets attached with this one, then I will see the fluorescence at the chromosome number 22. So, this will confirm me this case was suspected to be having problem at the chromosome number 22. I make a complementary strand for the chromosome number 22. When I allowed them to be hybridized, there was appearance of the fluorescence at chromosome number 22. It means yes, defect is present in the chrome. What I was suspecting clinically, defect is present here, which I can confirm by my fluorescence in situ hybridization. The theme is same for both, but that can be used for the new diseases where I need to know where is the defect. This is the I just prepared for the known disease a strand and I allowed it to be hybridized. Okay. Now see here, they will ask you which one is preferred. We can diagnose Williams syndrome by the fish analysis. We can diagnose Williams syndrome by the array analysis. We can diagnose CASH 22 by the fish. We can diagnose CASH 22 by the array analysis. Which one is preferred? Your array is the preferred modality of the choice. Right? Clear? Okay. So the difference between two is clear? And Dr. Zara, is that clear? Okay. So, yes, now we will move to the questions. Okay. Okay, yes. Okay, see a mechanism in the microarray comparative genomic hybridization. Detection of deletion of all chromosomes. It is going to detect deletion of all chromosomes. Detection of deletion of all. No, see here. It detect the number at a specific locus. This one is the best. It is going to unbalanced only. Dr. Hira, which answer? Let us see here. I'm going to read this question number 3. Now, see your mechanism in the microarray comparative detection of the deletion of all chromosomes. Microarray cannot detect both balanced and unbalanced translocation. That is basically for your deletion and micro deletions. Okay. Yes, it cannot detect translocations. They have given you example about deletion and duplication. Where there is duplication, there is the green color, and where there is deletion, there will be red color. Okay. Now see, it is going to detect of deletion of all chromosomes, fluorescent probe DNA in comparison with the other DNA, in comparison with the normal DNA, not the other, with the normal DNA. Specific segment of the DNA, yes, can detect single gene defect, not at all. Usually detect number at specific locus. Now see here, it is going to, we have to select the best one. Yes, it can detect the specific segment of the DNA. It can detect fluorescent probe, that is also used, but that is with the control DNA, not with the other DNA. They must have written here about the normal or the control DNA. But yes, it is going to detect the number. I told you we make a tray, we label it chromosome number 1 problem, chromosome number 2 problem. It detect the number at a specific locus. So if we talk about your cache 22 that we detect by the microarray, it detect the number of the chromosome, which number of the chromosome that is present. Okay. So among all these, this E is the best one. This is the correct answer here. Okay, the next one is, should I move to the next question? Okay, the next is father has sickle cell disease, mother know her state. Okay, maternal grandfather died from the sickle cell crisis. What is the chance of daughter to be a carrier? This is a simple case, like father has sickle cell disease. All right, father has sickle cell disease. Mother is not knowing her status. Mother may be normal, mother may be a carrier. Maternal grandfather died from the sickle cell crisis. So maternal grandfather, like the grandfather of the mother, he was having sickle cell disease. What is the chance of her daughter to be a carrier? What is the chance? Is this 100%, 50%, or this which one? This which we have discussed, that is your X-linked autosomal recessive disease. So, what is the chance of this one to be a carrier? Okay, yes. Mother, oh, that mother is also a carrier, definitely. See here, father with the sickle cell disease, he is also, mother is also a carrier. What is the chance of the daughter to be a carrier? Okay, so this is very simple. That is about the autosomal recessive disease. 50% chances to be a carrier. Mother is also having, like mother's grandfather was also having this disease. So mother is also a carrier. There is 50% chance to be a carrier, 25% chance to be disease, and 25% chance to be normal. Right. The next one. Okay. What are exons, introns? This one, these are basically the chromosomes, and where they will. This is an EMQ part of the DNA non-coding separating exons. This is basically, see here, introns, exons, or exons. If we see here, separation of the axon. So definitely this is not axon. Why? They have told you the non-coding separating axon. These are the part of your chromosomes. It has a coding part and it has a non-coding part. If father is carrier, it means both and XY of this father, they are affected. Okay. They are talking about the girl. What is the chance of her daughter to be a carrier? Okay. The daughter will definitely get this X disease. Okay. X from the father, that is affected. See here, if the mother is a carrier, right? They say mother is known, she's either a carrier, she doesn't know about her status. Most likely she will be a carrier. Why? Her grandfather, her maternal grandfather died from the sickle cell crisis. She may be normal, she may be a carrier. See here, if the father is having disease, it means his X is affected. So if we get a normal X from the mother, there is 50% chance to be a carrier and 50% chance to be a disease. If the mother is a carrier, then 50% chance will be affected and 50% chance of our daughter to be carrier. Yes, this 51 is the correct answer here. Yes, blue. It will, yes, right. Okay. So the next one, okay. The part of the DNA has a coding part and a non-coding part. The coding part is known as exon and the non-coding part that is known as intron, right? This has written in your SOP book. Cell contain one copy of the chromosomal number. Is this the correct answer? Yes. When the half copy of the chromosome, one copy is present, that is known as haploid. When two copies of the chromosome that is present, they are known as diploid. Okay. Next one, word to specify disease based on its clinical manifestation. So arrangement for the microarray CG was done. Which one of the following advantage of the microarray over the karyotyping? Okay, microarray can detect single gene amino acid substitution. Can detect single gene amino acid substitution. How we detect what single gene substitution? Not at all. That is usually done by your electrophoresis, right? If we talk about your HPC, if we talk about your sickle diseases and this one, can detect unbalanced translocation and inversion more. We have read not at all more than karyotype. It cannot detect translocation. It can detect mosaicism more than karyotyping. Usually not. Allows more detection of the chromosomal abnormality. Yes, this one is the answer. Chromosomal abnormalities. Which chromosomal abnormalities? Your deletions and duplications. Results within 7 days? No. What is the duration of the results? Karyotyping will give result after 4 weeks. And your no, CMA usually give results within 2 to 3 weeks. I will show you. Okay, I have taken from the Google. This usually gives results within 2 to 3 weeks. Okay, karyotyping will give you result after 4 weeks, and this will give results in 2 to 3 weeks. Okay, next question. 2 months old baby failure to thrive came to the GP with complaint of so slow growth. Microcephaly, weight is less than 0.4 centile, short forearms. This is the key point here. And no family history and fracture of the clavicles at birth. So whenever we have fracture of the clavicles at birth, what is your diagnosis? Is this a case of Russell Silver? Like he is microcephalic, he is slowing in growth, but this short forearm and fracture of the clavicle, that will not go with your Down syndrome, with your Russell Silver. With achondroplasia, yes, there may be short forearm that is present, but microcephaly is not going with this type of achondroplasia. They will be macrocephalic. Okay. Hypochondroplasia, they will also be macrocephalic. So this is a case of osteogenesis imperfecta. Clear? Okay, this is your microarray. This is the slide for the advantages and disadvantages of the microarray. Right. The next question. What is the most common cause of the Angelman syndrome? We have read it. Which one was the most common? That was deletion. Which chromosome? Parental. He has written parental, maternal. Okay, maternal disomy or single gene defect. So A is the correct answer. C, Dr. Fariha, C is the correct answer for this question number 8. Yeah, that is A, right. Child with the Dijor syndrome, what is the embryological defect? In the pharyngeal arches, that is third and fourth pharyngeal arch. See here, third and fourth pharyngeal pouches fail to differentiate. That will give to your Dijor syndrome, and there will be absence of the thymus and the parathyroid gland. Right. The next question, congenital myotonic dystrophy. Now see here, they may ask you about is this genetic anticipation, autosomal dominant, and the triple nucleotide repeat. These three ways for asking this congenital myotonic dystrophy. Family pedigree, that was the X-linked recessive, no generation gap that is present, male, female, they all can be affected. Okay, SMA, what is the SMA? That is, what is the diagnostic investigation? That is the genetic analysis. Where is the defect? In the SMN1 gene defect. Like in your genetics, you will get recalls like this. You have to memorize what type of genetic defects they are present. This is about the Angelman syndrome. We have read it. The most common type is deletion. Okay. Next one, they have given, this is your EMQ. Okay. These now we basically read what the genetic present clinical presentation of different syndromes can be present. Okay. Male affected in X-linked recessive. Yeah. Males are affected. Yes, males are affected in the X-linked recessive. Okay, sorry, I was thinking of autosomal recessive. Okay, next is an obese child who is 4 years with the cryptorchidism and descended testes, small hand and feet, with history of the poor feeding and hypotonia in the neonatal period. What is your diagnosis? What is your diagnosis here? Yeah, Prader-Willi syndrome. What is the most common type? Is this X-linked dominant? Is this codominance? Is this microdeletion, genetic anticipation, multifactorial, X-linked recessive, histone proton modification? That is microdeletion. Usually deletion. Here they have given the word microdeletion. Okay, next. Female 9 month presented with bone pain. Okay. X-ray showing cupping, fraying, frontal bossing. Mother has bowing of her legs. What is your diagnosis here? What is diagnosis here? Yeah, this is X-linked hypophosphatemia rickets. That is X-linked dominant. Okay, right. Next, baby on the mechanical ventilator, hypotonic. His uncle has cataract, and mother cannot smile. What is your diagnosis here? Yes, myotonic dystrophy. Okay. Next is coming. What is the definition of the genomic imprinting? Okay. Now see here. What is the definition? One set of the chromosome inherited from one parent only. Methylation to change expression of the gene. Environmental factors, epigenetic from one parent. So what is epigenetic? There are genetic problems and there are epigenetic problems. Okay. Is the genomic imprinting is epigenetic? Genetic means problem is in the DNA. Mutation. Okay. Epigenetic mean along with your DNA problems, your mutation problem, your environmental factors are also going to contribute to the expression of the disease. Like if we talk about our diabetes, there is HLA typing that is present. Okay, but whenever we see, like whenever there is some viral infections, they come. And if we talk about our celiac disease, there is HLA typing that is present when we eat wheat or something like gliadin, then that the expression of disease will come. So whenever we have environmental factor plus genetic factor, that is known as epigenetic. Only environmental factor not going to affect your genomic imprinting. Okay, one set of the chromosome inherited from one parent only. This is the definition for the uniparental disomy. That is a type of the genomic imprinting. I have told you the different ways. That is a genomic imprinting. Imprinting is basically by your methylation mostly. If we go again to your SOP, Tafriha, see here, the ways for the genomic imprinting, the top, see here. This is methylation. Every here methylation is on the top. Methylation defect, see here. Yes, it can also cause, but it is not the common one. Methylation defect of the normal pattern in imprinted region can disrupt the normal parent of origin specific expression of the disease. This one is most common. Yes. Parental disomy, that see here, I will tell you like all the things that will be present, but we have to see which one is most common, which one is going to cause this imprinting. Okay. That is basically your two is the correct answer here. That is also, see here, imprinting mean, what do you mean by imprinting? Okay, imprinting means this has become defective. What was the genome? This, if we talk about this chromosome, yes, that is a part of this one, but it is less common as compared to this methylation and other defect. And if we talk like imprinting means this genome that is present, but that has been imprinted. If we talk about the uniparental disomy, it means there is absence of the gene from that mother. Autosomes, yes. If they have written autosome, if they ask you about the uniparental disomy, then this definition will be more accurate. These one and two, these both are correct. But if we talk about like this two one, yes, imprinting that gene, it is present, but it is imprinted. Okay. All right. So the next question, pedigree, again, that was of the X-linked recessive. This is the Prader-Willi. Okay. This is the definition for the epigenetics. That is your behavior, environmental factors that they are going to change the DNA sequence. Okay, the next one, again, this is again not a right. See here, they have told the answers, terminologies, they were a bit different, but this is what we could remember. This is not a good recall. Let me read it. That is, no, they are not talking about, they are saying, what do you mean by the genomic imprinting? Like, how do we get imprint of the gene? Yeah, that is different. No, see here, basically the point here is, if we talk about the uniparental disomy, that yes, they are going to lead towards the imprinting problem, 1 and 2 both, they both are correct. Okay, like see, if they ask specifically that about uniparental disomy, yes, that is the mean. The two chromosome, we have got these two chromosome from one parent. Genomic imprinting mean gene is present, but that is imprinted. Okay, so that is why they have chosen. But yes, answer 1 and 2, these both are correct. If something they will not like, usually they do not make it wrong, like if someone is writing this option 1 as a correct option. Okay, right. The next, this question they have told here, like this is not a correct option, correct statement of the question. Let us read it. A father who has a sickle cell disease, a father who has a sickle cell disease, a mother is a carrier, pregnant with monozygotic female twins, which what is the chance of them having full blown out disease, meaning affected? Like how many? What is the chance? 50% independent for each, 50% dependent for both girls, 25% carrier for both, 25% independent for each. So, what is the chance for them to be a disease? This is, see here. Okay, this one and this one is going to be X and X, that is diseased. Okay, now this one, this boy, a carrier, and this boy are diseased. So 50% chance to be diseased. Now see here, they have told here like the answers terminologies, they were quite different. We could remember. So there are 50% chances for them to be disease independent. 50% of the girls that will be disease, and 50% of the boys that will be disease. Right? The same, this is the same question. The father known sickle cell disease, mother is a carrier. They got monozygotic females, twin asking about carrier rate for each child. That is 50%. Right? Okay. The next is baby with a velocardial facial features. How to confirm the diagnosis? Is this a fish analysis, microarray analysis, or karyotyping? Okay. Which one is the answer for the question number 19? Fish analysis. Now see here, the difference between one point was that where I know this is the problem in the velocardial facial defect, what is my diagnosis? That may be a case of Dijor syndrome. I know where is the defect. This is the chromosome number 22 defect. I will just make a probe for the chromosome number 22 and I will allow it to be hybridized with my patient DNA. So here, when you know the disease clinically, this fish analysis is the better one. When I do not know, but I have some clinical features, then microarray will be the preferred one. Okay. Microarray, what it tests? Missing are extra DNA sequences. Now see here, missing means deletion, extra means duplication across over the chromosomes. Specific nucleotide repeat sequencing, like they want to ask you about your genetic anticipation. This is the preferred one for deletion and duplication. Okay. This is the fluorescent in situ hybridization. They have given the example of this 22q here. Okay. This one, these are the two strands of the DNA. One is separated, okay, and then a fluorescent is made to unite with this one. If it goes or attaches at the number 22 or known chromosome, then it will give fluorescence at that chromosome number. Okay, the next one, again repetition, intron, exon, and all of this. This one is the same, right? A newborn is diagnosed with the late disease and he's suffering from the developmental delay, seizures, dysmorphic features. His mother has mild cognitive delay, father is normal. So this is a mitochondrial problem. Okay, the mother is having the disease, mild cognitive delay, father is normal, genetic testing is done for mother, show mitochondrial DNA mutation. What is the risk of having another affected child? 50% of all affected will be. Now see here, mother is having mild cognitive delay, mother is having problem here, and the father is normal. So what is the chance? Yes. Why this is the answer? Yeah, this is from the mother's mitochondria. They are having problem. So every child is having 100% chance that he may be having this frequency. Yeah, C is the correct answer. Which one of the following is an example of aneuploidy? I told you. What are the examples of the aneuploidy? Okay. Aneuploidy means odd number of the chromosomes, 47 XYY, right? It should be 47 double XY. Okay. This is again the repetition of the question. Like, so arrangement of the microarray, what is it can detect, allows more detection of the chromosomal abnormalities. Fish analysis is used for which of the following? Williams syndrome, Down syndrome, or SMA. For SMA, we go for genetic testing. For the DNA analysis, DNA sequencing, Williams syndrome is diagnosed by the fish, right? Okay. The next one, most common type of the Angelman syndrome, the same repetition. Father is 59-year-old, mother is 23 years old. They have a Down syndrome baby. What is the most common cause? Maternal non-disjunction. Okay. A fish one, see here now. They want to ask you, fish is used for which one of the following? Is that used for the Williams syndrome? We know the chromosome. That is the chromosome number 7. Okay. So Down syndrome, they are diagnosed by which type? Okay. Down syndrome are diagnosed. For Down syndrome, we go for quantitative PCR at the first day of their life, which comes early. Then we go for karyotyping. A is the answer for the question 25. Okay. Okay. Should I move forward? This is Williams syndrome. For 25, A is the answer. See here. Can we detect Williams syndrome by the fish? Williams syndrome, yes, we can detect by array or fish analysis. Okay, next, Down syndrome coming with the sudden onset of the quadriplegia. What is your diagnosis? Is this hydrocephalus or atlantoaxial subluxation? This is atlantoaxial subluxation. Okay, a very well-known complication or disease are part of presentation, right? Family history of the states, which one of the most to do screening for early in the childhood with a clinical importance from these autosomal dominant diseases. Long QT syndrome, HOCM, Burgada syndrome. This is basically Burgada syndrome. That is also a part of your long QT syndrome type. Arrhythmogenic cardiomyopathy. So is one is the answer, this one or this one? If we talk about the states, that may be cardiac defect or that may be a cause of your inborn error of metabolism. Okay, why we have selected here type 1 is the more dangerous, that is causing cardiac arrest even at sleep. So 1 is the correct answer here. Okay, next, this is again the repetition of the same sickle cell, 50% chances. Turner mechanism, that is non-disjunction microdeletion imprinting a unimaternal disomy. So what is the answer here? This is aneuploidy where 45 but 1X that is missing. Chromosomal non-disjunction. Yes, this is a correct answer here. Okay. Next, the same repetition congenital. This one, baby with cleft lip and other physical signs. What genetic association mostly present? This was basically a scenario of your Dijor syndrome, 22q11 microdeletions. Okay, so from here we got to know, like we must know, clinical features are some 4 or 5 syndromes, especially your myotonic dystrophy, your Down syndrome, your this Dijor syndrome, and what else? Your Prader-Willi syndrome, Prader-Willi and Angelman syndrome. Yes, these 4 or 5 syndromes, these are important to make your diagnosis. Okay, this was about your genetics recalls. Okay, next we are going to rheumatology recalls. These are very easy. We have done it like let us read it. Very easy. For just I think 4 or 5 recalls from that. What commonest, sorry, the first 13-year-old girl with the fatigue, mouth ulcer, decrease in weight, and pleurisy, IgA that is high, IgM, IgG that is normal, normal platelet, normal neutrophils, high urea and creatine. What is the investigation to reach the diagnosis? Basically, in the exam, you will get long scenarios. Okay, you have to go for the here they have written that was a normal platelet count. In your real scenario, they will give you platelet number is 320, your neutrophil count that is 60%. Okay, so we have to interpret there what is the normal value. No, no, Dr. Zara, nothing more from the genetics now. Okay, so then what is your answer? This is a case of SLE. Okay, for SLE, what is your investigation of choice? That is your anti-double stranded DNA, right? The commonest among children associated with HLA-B27. So HLA-B27 is associated, number one, your inflammatory bowel disease, and number two, that is enthesitis-related arthritis, right? What is the association of your HLA-DQ2 and DQ8? Yes, pedigree is usually of autosomal dominant recessive and X-linked recessive. Yes, Dr. Hira, they can give. Okay, celiac, that is celiac, right? The celiac and diabetes mellitus, both. Okay. The next one, the commonest among the children, same repetition, that is enthesitis related arthritis. Okay, next, this is the same repetition, the first question, a case of SLE now coming with the alopecia, low C3, low C4 levels, lymphopenia, low albumin, normal immunoglobulins, pleurisy, palate ulcers, this one. This is a case of SLE. Thyroid? No, not at all. That is Hashimoto's thyroiditis. Yes, that is also associated with the DQ, I guess 3 or 4. Please confirm it. But in HLA DQ2, and 8 most likely that is diabetes and celiac disease. Okay. Next, the last question about this task, rheumatology. Patient has abdominal pain, petechial rash in the lower limbs and the buttocks. Diagnosed as HSP. What is the pathophysiology? Toxic vasculitis necrotic. This is the IgA leukocytoclastic vasculitis. That is also the pathology of your IgA nephropathy. Okay. Any ambiguity, any confusion? I guess these are very easy and very clear. Okay, this was your rheumatology. Next, we are going to your dermatology recalls. Okay, we have done the clinical cases. These recalls are basically the lines of your clinical cases. Okay, now see here, 14-year-old boy with severe acne. We have read what is the mechanism of the acne, what is the pathophysiology, excessive sweating, not at all, decreased sebum production, increased sebum production, follicular hyperkeratinisation. Yes, among colonization of the Corynebacterium, that is with the bacteria, not with the Corynebacterium especially. Okay, in the hair follicles, there is increased inflammatory process that is present in the hair follicle, but not with the special Corynebacterium. C is the correct answer. Newborn discharged well at 9 days of the age with the midwife found on routine visit to have blisters and nail dystrophy. This is a newborn. Okay, which layer is affected? What is this? In your some of your AKP recalls, you will see they will give you a question. The newborn who is just 1 hours old and he is having peeling of the skin blister. So my diagnosis is epidermolysis bullosa, or my diagnosis is staphylococcal scalded skin syndrome. In the SSS, they usually take 1 or 2 days, or after infection there is incubation period, then blistering will occur. Whenever within first day of the life, few hours of the life, we have this nail problems, we have blistering. This is epidermolysis bullosa. We have to know this is epidermolysis bullosa. Simplex, junctional, this is autosomal dominant or recessive. This is not a simplex. In the simplex, it will not appear right after the birth, not within the first few days of the life. Okay. Why this is not a case of SSS? The patient has come to you at the 9 age due to the presence of the nail dystrophy. Okay, this is epidermolysis bullosa. Which one? Junctional. Why? It is an autosomal recessive that is coming early in the days of the life. The simplex one, it appears when the child begins to move, when the child becomes older, like within 1 year, not at the days of the life. Dermoepidermal, for that, see here, there are types of the epidermolysis bullosa. We need to know which layer is affected. In the simplex, epidermis is affected. Okay. In the junctional nebulosa, there is dermoepidermal junction that is affected. In the dystrophica, there is also defect in the dermoepidermal junction. The problem in between the basement membrane and the upper dermis. Okay, dermoepidermal junction, and in the Kindler syndrome, it happens multiple layers of the skin, including the basement membrane. This the problem that is in the epidermis, that will be without scarring. Mm, but when the problem goes deep, it becomes with the scarring, blisters with scarring that will be present. Okay. 2 month girl with a hemangioma coming to you, that is increasing in the size from the age of 3 weeks till now, bleed from the scratch. What is the origin of the capillary hemangioma? That we have read it from your clinical cases. This is from the dermis. Why from the dermis? We have blood vessels which are present in the dermis. Okay, the origin of the blood vessel, the origin of the nerves, that is down in the dermis, and your blood vessel, they are arising from the dermis. Okay, here they are arising from your epidermis, deep layers of the epidermis. Sorry, dermis superficial layers, that is the papillary layer, and the deep one, that is known as a reticular layer of the dermis. Okay, so from the dermis, blood vessels are arising. So we have capillary hemangioma, which are arising from the dermis of the skin. Okay, the next is, sorry, flagrant gene defect, which this is from your clinical cases. Okay, we will see That is your atopic dermatitis. That is the problem in the chromosome number 1 where flagrant gene that is defective. Okay. Child with a blisters layer affected in the staphylococcal scaldate syndrome. Which layer is affected? This we have read from your clinical cases. There was a table where they have given different diseases and different layers of the skin which are affected. In that table, they have mentioned what are the diseases with scarring and what are the diseases which are without scarring. So you have to read for that table again. Okay. So stratum granulosum, that is the layer that is affected with the staph aureus. Okay. I have not like taken the screenshot for that. We have discussed all the clinical cases in detail for of this dermatology. Okay. Burn superficial thickness. What is the deepest layer affected? That is your papillary dermis. There are two layers, papillary and dermis. This I also have shown you in the clinical cases. The burns, which layers are affected, given in your illustrated and SOP book. Okay, so this is the papillary dermis that is in the superficial partial thickness, your first degree burns. Okay, eczema again, what's the defect? That is in the flagrant gene. This is okay. Baby with a congenital melanocytic nevus, this we have discussed one time in our group, like where are the melanocyte, in which layer of the skin? This is in your stratum basale. See here, these are the melanocyte, which is stratum germinatum they have there. That is also known as stratum basale. So the same question they have asked here. From this, we are coming to know, like we must know what are the layers of the skin and which layer of the skin that is affected in different type of the diseases. Okay, right. What is the layer affected in the epidermolysis bullosa simplex? That is the basement membrane. Now see here, in the simplex, I told you that is not with scarring. So with scar, it is gone. With scar, it is gone. With scar, it is gone. I have to choose between without scar. Yes, without scar. Is this the basement membrane or intraepidermal? What do you mean by intraepidermal? Intraepidermal means all the layers which are affected, that is the basement membrane without scar, it is affected. This is written in your clinical cases table, which layer is affected. So this one is the correct answer. Okay, this is again the first degree burn, your papillary dermis that is affected. Right, this is the capillary hemangioma that is arising, your dermis. Repetition of the question. Okay, baby with the flagrant gene defect on the chromosome number 1, which of the following is associated with the gene defect? That is the atopic eczema. Yes, we have read. See here, atopic dermatitis. This is flagrant gene chromosome number 21. Sorry, chromosome number 1. That is affected. Now let us see for the other option. For the pemphigus, see here, there is the this MHC locus in the HLA class 2 allele that is defective. They have not given me here about the flagrant gene chromosome 21. This is the histocompatible proteins which are defective, your HLA defects which are present, like your immune system that is defective. What about the vulgaris, acne vulgaris? First degree burns, sorry, what we have talked about? In the first degree burns, yes, sorry, this is basal layer. I just took it, your superficial partial thickness. This is the basal layer, epidermis. Okay. Now this one for your for the your acne vulgaris, they say there is until recently solid genetic association that is lacking for your acne vulgaris. So from this scenario, this is your atopic dermatitis. Okay. The deepest layer to be affected in the full thickness burn is this dermis or adipose tissue. What happens in the full thickness? This goes to deep down to your layers, that is the adipose tissue. If we see the structure of the skin, see here, this is the hypodermis where the adipose tissue that is present in the full thickness burn. There is no pain. Why? all the nerve endings, they are also destroyed. So it goes deep down to your dermis. Let us see what they have given us among the options. Where this goes up to adipose tissue. Okay, 2 is the correct answer for the full thickness buns, right? Okay, the next one, a girl with the erythematous itchy skin in the site of her. This is about your contact dermatitis. For that, a case, clinical case in your FOP book. If I memorize what is the clinical case number, again a chapter that has been given where they have told us the different type diseases and different types of the reactions. Your contact dermatitis, that is your type 4 hypersensitivity reaction. Okay, your celiac disease, that is your type 5 hypersensitivity reaction. Okay, please, I will search which clinical case is that, but that table is very important for your FOB test and for your test both. A girl with the erythematous itchy skin in the site of her nickel, okay, ear piercing. What is the type of the hypersensitivity here? This is type 4. That is celiac, which is basically autoantibody mediated. Okay, your autoimmunity is your type 5. Okay. The next, this is the burn superficial partial thickness, that is the papillary dermis. Okay, skin prick testing, that is a type 1 hypersensitivity reaction. Ichthyosis vulgaris, that is associated with your flagrant gene mutation. Yes. Your ichthyosis, that is associated with your atopic dermatitis, that is also associated with this one. Okay. So these were all the questions, especially your dermatology. Each question is from your clinical cases. Okay. With this, we will finish our class today. I was thinking it will go to 3 or 4 hours, but yes, it has gone just 2.5 hours. Okay, inshallah, tomorrow we will do with your infections, vaccination, the topics which we are left from the clinical cases. Uh, Dr. Hira, as 1 minute, methylation defect, you want to go to that question or just the methylation defect? Inshallah, Dr. Priya, we will do tomorrow. These 3 days we will try to cover what we have planned in our schedule. Methylation defect, okay. This one, basically, Dr. Hira, the answer for that question, the both, see here, methylation defect is basically detected in your Prader-Willi syndrome. See here, in the Prader-Willi methylation defect that is present. Okay, in that question, uh, methylation defect, see here, that is, they have given in the Prader-Willi syndrome, there is a methylation defect that is 1%. Okay, no, if I told you, like, see here, the imprinting, the problem, see here, this is the gene, it is present and it is methylated and it is imprinted. Okay, in the uniparental disomy, the gene is not present. There is absence of the gene from the father. So that gene is not imprinted basically. It is going to behave just like the gene that is imprinted, means it is silent. It is present, but it is silent. Okay. And the most common type for that is methylation, not the hydroxylation, not the other ways, not the deletion, not the single gene mutation. Imprinting means that was present, but that was imprinted by the defective methylation. Okay. And if we talk about the uniparental disomy, the gene is not present. It is just like behaving like the imprinted gene, which is present but it is not functioning. And in other case, that is not present, and obviously when it is not present, it is not functioning. So the way of presentation will be the same, but the defect is the different. Okay, all right. So with this, we are going to finish our class today. Inshallah, we will do tomorrow our class with vaccinations and your allergy and other topics. Okay, I have reviewed this pharmacology records. Just I got 10 questions which were new, and we will do them. Like not there was a long list of the questions, almost 75 questions, very long. We have discussed them all. Just few they are not discussed. We will discuss them. No, not in a separate class for that. Okay. So